Good morning. Welcome to Medical Grand Rounds. It certainly is my honor to introduce the speaker for our starting Grand Rounds for 2020. My friend and colleague, Dr. Nizar Jarjour, is Professor of Medicine and head of our Allergy, Pulmonary, and Critical Care Medicine Division. He graduated from Damascus University School of Medicine with highest honors in 1980. He completed internal medicine residency at Cook County Hospital in 1986, where he was elected Resident of the Year. After that, he came to UW for a Pulmonary and Critical Care Fellowship and has remained here since, rising through the ranks to become Professor of Medicine and head of the Allergy, Pulmonary, and Critical Care Division in 2004. Since 2016, he has taken the role of President of the University of Wisconsin Medical Foundation, providing physician leadership to nearly 1,500 physicians in our faculty practice plan. Dr. Jarjour has received a number of awards and recognitions, including election to AOA in 2015, the UW Health Physician Champion Award in 2013, and in 2012, he received the Department of Medicine John Rankin Award given to senior faculty for outstanding research accomplishments. In addition, he has delivered a number of named lectures at prestigious institutions and professional society meetings. He has served on the American Board of Internal Medicine, Pulmonary Specialty Committee, the FDA Advisory Committee on Allergy and Pulmonary Drugs, in addition to NIH study sections and other grant review committees. For more than 2 decades, Dr. Jarjour has led an internationally recognized NIH-funded research program focused on the mechanisms and treatment of asthma. His work has resulted in nearly 200 papers and more than 1,000 annual scientific citations. The role of eosinophils in asthma has been a long-standing focus for his laboratory, and we are delighted that he will be speaking to us this morning on Eosinophil-Related Airway Inflammation and Remodeling, Clinical and Therapeutic Implications. Please welcome Dr. Jarjour.
Thank you. Thank you very much, Alan. Good morning and Happy New Year. Thank you all for coming. It's my pleasure to speak to you today about a topic that's near and dear to my heart and the heart of many here in Wisconsin at the University of Wisconsin-Madison, which is the role of eosinophils. These are my disclosure. NIH funding is the sole funding in my laboratory. I'm not planning to speak about any treatment off-label, and in the past 3 years I got consulting from 3 drug companies listed here. My objectives are to discuss the potential role of eosinophils and their function, highlight their contributions to airway inflammation, particularly focusing on how we can use allergen models to test that, and how our studies and similar studies at other institutions focus on the role of IL-5 in promoting eosinophil function. Then move on from inflammation to remodeling and discuss the effect of allergic inflammation on fibroblasts and airway smooth muscles, mucus gland hyperplasia, and fibrosis. Then we're going to consider the systemic implication of eosinophil and asthma. This is an area that is new and expanding for our program, working with cardiology to look at cardiovascular event and with geriatrics and psychiatry to evaluate neurodegenerative changes related to asthma, and we'll hopefully leave time for questions. So, what's the cell that we love so dearly? It's a bone marrow-derived cell that is promoted under the effect of 3 cytokines that overlap in their receptor, IL-5, IL-3, and GM-CSF. It's characterized by all these eosinophil-loving granules and the bilobe nucleus. And under the electron microscopy, we can see these very unique granules that have various toxic proteins, such as major basic protein, ECP, EDN, and eosinophil peroxide. In addition, a number of cytokines and chemokines and mediators. If you want a more detailed list, here it is, an eye chart, and not even a complete listing of all the cytokines and the chemokines, and the product that these cells use to communicate with other inflammatory cells, as well as to create other effector functions. Most of my talk will focus on this lower right corner of the slide with the effect on airway, as well as we're going to touch upon a new area of research looking at the cardiovascular implications. So in asthma, eosinophils are a landmark feature of allergic inflammation, and they have mediators that can contribute to the histopathology of allergic disease, including asthma. They are increased in the circulation as well as in samples from the airway, and often the amount or the number of eosinophils and their function relate to the disease severity as well as risk of exacerbation. As I said, this is near and dear to our heart. This is a picture from the about 2 decades ago of a statue of the eosinophil that used to live at the lake home of Dr. Bassi, and here's a few of us surrounding this cell that we've studied for more than 2 decades. Since then, that statue has moved to the first floor of Wimmer, and we have some of the same and some new members of this project grant that is focusing on the study of eosinophils. The program project grant had a simple hypothesis that we believe the eosinophil is an important cell influencing the pathogenesis of airway inflammation and remodeling. We have 3 projects and 3 cores, all focused on doing these studies, and some of what I'm going to show you is the result of our collaborative efforts. So we'll start with airway inflammation. So what does the eosinophil do in airway inflammations? We do know that allergies are very important in asthma. Somewhere between 60 to 90% of people with asthma have known allergies, and we know that these allergies are important not just for having asthma, but also for exacerbation. That's why people, when they get exposed to, the ragweed and cats and dogs, they get wheezing and asthma symptoms. We have exploited that phenomena to study the response in the laboratory by asking volunteer subjects to inhale allergen they're sensitive to in a graded, controlled manner, or instill the allergen in the airway. By doing that under controlled situation, we can actually study the events that happen in response to allergen challenge and try to understand this better so that we can devise improved and new therapies for patients with allergic asthma. So what happens when you inhale allergens? From many studies, several of them have done right here at Madison, we know that if you give somebody an allergen to inhale, that they're sensitive to, often they'll have an early phase response. So the lung function drops typically within the first hour, and then recovers. It goes back pretty close to baseline. So this is the drop in the early phase within the first hour, go back to baseline, and typically it stays there for a couple hours. And about 50 to 60% of the patient is followed by a second phase, what we call the late phase response, where the lung function without any other allergen inhalation, it drops down again. What happens? Well, in the first hour, what happened is the release of mediators that cause the bronchospasm and edema. But in the second phase, these initial mediators called in inflammatory cells, such as the eosinophils, and that inflammatory response is what's causing the late phase response. And this is the kind of the closest we have to chronic allergic asthma. Well, we wanted to actually study this with a bit more precision. And our institution, as well as a few others around the country, took advantage of bronchoscopy to actually introduce a bronchoscope to various segments in the lungs. And in one segment, we can install a saline as a control, but we go to another segment in the lungs, And we wedge the bronchoscope and instill a dose of allergen that's titrated to the person's response. And we can go to another segment and put a different dose of allergen to try to figure out the dose response. What we're doing here is we're creating a localized, very precise and controlled acute asthma exacerbation within that one segment, the 1/20th of the lung. And if we do that and come back 48 hours later and do a lavage, the saline segment will have normal-looking cells. They are mostly healthy-looking macrophages. But the segment that we put allergen has a lot of inflammatory cells, namely the eosinophils. We go from having 1% eosinophil to having 20, 30, 40% eosinophils. Here's a study where we did 3 different doses of allergen, and we looked at the dose response. And in the red is the BAL done at 48 hours. And you can see that when we put no allergen, there is hardly any eosinophils, and then low, medium, and high dose, progressively greater proportion of eosinophil in the airway, in the lavage fluid. So what happened in the biopsy? Something very similar happened in the biopsy. You take a sample from the saline segment, healthy-looking bronchial mucosa, a sample from the allergen challenge segment, a lot of these pink cells and infiltrating the mucosa, and almost appear to be lifting off that epithelium, sloughing off because of the damaging mediators and toxic protein, that integrity of the mucosa is now disrupted. What we've also studied is that why these eosinophils are being recruited, and from studies by our group and others, what we know is the most important factor in bringing this eosinophil is IL-5, and we know that the more IL-5 you have in the BAL fluid, the greater the number of eosinophil there. So this is a pretty directly linked to IL-5 production by lymphocyte in the airway, and that and other studies formed the hypotheses and the justification for trying monoclonal antibodies against IL-5 to try to see whether we can control the allergic inflammatory response in asthma and improve the patient and risk of exacerbation. And lo and behold, once the studies were done in patients who have allergic asthma, who have eosinophilic disease, they were shown that these things work. So here's a study. This is the pivotal trial for anti-IL-5. And there are 3 doses of the monoclonal antibodies as well as placebo. And this is the cumulative risk of exacerbation since the treatment started. And over a 1 year's time, you can see that regardless of what dose of that monoclonal you use, there is about 50% reduction in the risk of exacerbation. Now, you might ask, but you selected patients who have eosinophils, and you selected patients where we think eosinophils are playing risk of exacerbation. Why is the reduction in exacerbations only 50%? This is a very intriguing question. And to try to answer that question, what we did, we went back to our model of segmental allergen challenge. And we said, let's see what will happen if we actually treat patients with monoclonal antibodies against IL-5 and repeat those same studies doing segmental allergen challenge. What happened to the eosinophils? Do they come? Do they not? And what might be an implication for that? This is a bit of a complicated slide, but I'll walk you through it, and then I'll show you a summary of those findings in subsequent slides. So what you're looking here at the eosinophil in the blood, and we know that the eosinophil, if you give, at baseline, they're about 250, 260. If you give allergen by the airway route, there is an increase in eosinophil in the blood, doubling, if you would. If you give monoclonal antibody against IL-5, even 1 dose, look at that, what happened to the eosinophil. They are annihilated. I mean, we're talking about 80% or more reduction in eosinophil with 1 dose of the monoclonal antibodies. They just die. Now, what happens when we do the segmental challenge? I showed you at baseline, this is what happened. This is only 2 doses as opposed to the 3 doses in the previous studies, but same thing happened. This is a very predictable model. You put allergen in the airway, you come back 2 days later, you lavage, voila, plenty of eosinophils. Here's what happened after you give them Mepolizumab. Quite a bit of reduction in the eosinophils, 70% less. That seems to make sense, and that's what you might expect. There's less eosinophil in the blood, there is less to come to the airway. But here's where things get really interesting. We're looking at the biopsy to see what actually happened in the tissue. And to be more accurate, we stain these biopsies for EPX, which is one of the granule proteins in the eosinophils. And we were surprised to find out that a lot of this is kind of a distinct cells, but a lot of the biopsies really did not have a lot of distinct cells, but had this smudging of red where the protein has really left the cells and is just infiltrated in the tissue. So we really could not do this justice by counting cells, so we had to really do a semi-quantitative measure of the red coloring, which indicate the eosinophil cells as well as their product. So here is again, let me show you what happened with the tissue after we did the semi-quantitative, 0 to 10 staining. So this is when you do as a baseline. At baseline, the count was 5, and then after allergen challenge went up to close to 9 or so. So pretty significant increase in the number of cells after allergen challenge in the tissue, very similar to light microscopy that I showed you earlier in the previous study. What happened after Mepolizumab, after anti-IL-5, is a pretty dramatic increase in the tissue. So we had hardly any effect on eosinophils and their product in the tissue, even though that we reduced the eosinophil in the blood by more than 80% and in the BAL by more than 70%. So what's happening here is that the eosinophils are now getting stuck in the tissue, in the airways, and spewing out, cytolysing, releasing their granules and their toxic protein in the airway. And we believe that is the reason why these patients continue to have exacerbations. So to show you that again, to summarize this, with anti-IL-5, the staining goes significantly down goes down, but not significantly so in the tissue, while the BAL fluid goes, and the blood goes dramatically less. So the cells get stuck in the tissue somehow. And we are working diligently now to try to find out all the mechanisms and what are the potential implications for that. So one of the theory that we are pursuing has to do with the receptors on these eosinophils. I told you that there are three main cytokines influencing the eosinophil function: IL-5, IL-3, and GM-CSF. And what we have observed in studies in our laboratory, that while the eosinophil number dramatically goes up in the BAL fluid, the receptor for IL-5 is dramatically reduced. That receptor is totally shed. Now it's making a lot of sense why the IL-5 antibodies does have a lot less effect on the lung eosinophils, because they don't have any more IL-5 receptors. But what happened to the other cytokines, the cousins of IL-5, IL-3 and GM-CSF, their receptor actually goes up. This is IL-3 receptor, goes up. So now we have a shift from an IL-5 responsive cell to an IL-3 responsive cells, and you wonder, does IL-3 goes up in the BL fluid? You showed us before that IL-5 goes up. How about IL-3? Well, lo and behold, IL-3 goes up significantly in the BAL fluid. So now we have a story where IL-3 goes up as a protein, IL-3 receptors on the cells go up, and voila, IL-5 now is no longer the important cytokines, it's IL-3 that's the important cytokine. So now there's a shift in that cell responsiveness and in their personality, if you would, as they move from the blood to the airway and the tissue. And that is, I think, a story that is very exciting to us, because there are very, very few studies now that have looked at why this actually happened. And we believe this avenue of research will actually inform the future treatment for eosinophilic asthma. So I'm going to summarize the first part of the talk by hopefully having shown you that the eosinophil play a very important role in airway inflammation and its clinical manifestation, particularly risk of exacerbation. The second thing that we talked about is IL-5, that this is a really critical cytokine for the eosinophil survival, as well as activation and recruitment. Monoclonal antibodies, I showed you one study, but there's a bunch of studies that have shown this time and again that they're pretty effective in reducing exacerbation, but regardless of what antibody you use, they're all good for 50% only. So there's still a number of exacerbations that is not controlled by anti-IL-5. And we think that this could be because you have no longer have IL-5 receptor in the cell. So, maybe that they cannot work because there's not an IL-5 receptor. Or maybe now we need to do something about IL-3 effect, because there is a shift with IL-3 going up and IL-3 receptor on the eosinophil going up. Maybe now the cell is has much more affinity to IL-3, and the downstream events from IL-3 are more important now. Or maybe some progenitor cells in the airway under the influence of allergic inflammation are developing into eosinophils. We don't know which one of these is true, but we know that some of the evidence really point toward the role of IL-3. And I believe that understanding the role of these eosinophils that are stuck in the tissue and their recruitment and activation and how they release their granules is really critical to help us improve the outcome of these patients who have eosinophilic asthma. Moving on from inflammation to remodeling. So what's remodeling? Remodel your house, you change the shape, you change different rooms. When you remodel the airway, you're changing the structure of the airway. And when we looked at the structure of the airway for many years, starting with autopsy studies in the previous century, all the way to doing studies in volunteers with asthma, what we have learned is that in general, patients with asthma have increased fibrosis under their basement membrane, increased matrix protein and slightly different composition of the matrix protein. There's angiogenesis, increased airway smooth muscle mass and activation, and mucus gland hyperplasia, as well as goblet cell hyperplasia. This collective change in the structure leads to thicker walls and narrower lumen, and we believe that this is important for disease severity, lack of reversibility with bronchodilator inhaler, potentially progression, morbidity, and the poor outcome in patients. So schematically shown here is a patient on a normal healthy airways and a patient with asthma. And you can see that the wall is quite thick. There's a lot of secretions, and there's a lot of airway smooth muscle and fibrosis. So you don't need to do a lot of analysis to know that the patient with asthma who have this extensive remodeling will have a much harder time breathing than normal healthy airways. On this tissue sample, what we are really highlighting is this subbasement membrane fibrosis, which has extra matrix protein, such as collagen and fibronectin. Well, we wanted to figure out what's the genesis of fibronectin. So we did, again, we went back to our experimental model and measured the level of fibronectin in the airway samples before and after the allergen challenge. And lo and behold, if you look at day 0, the levels are pretty low, but 48 hours after instilling allergen, the levels are significantly increased, suggesting that eosinophilic inflammation is probably important for generating extra matrix protein. And we do know also that the responses are correlated. So the more eosinophils you have coming to the airway, the higher level of fibronectin matrix protein, which is one component of airway remodeling. Another component of remodeling is airway smooth muscles. Patients with asthma have increased airway smooth muscle mass. And again, very simple. If you have a lot more smooth muscles with a given stimulus, you're going to have greater contraction and more airway obstruction. So this is a biopsy from a young college student who volunteered for one of our research study. Importantly, this patient had mild asthma, but he still had quite a bit of airway smooth muscle. Another feature of this patient is that the airway smooth muscle are pretty close to the airway. So the closer they are to the lumen, the more they can constrict and the greater their effect. Here's a study that looked at quantitative analysis of airway smooth muscle. They looked at healthy controls, people with mild asthma, people with severe asthma, and COPD. Obviously, just looking at this selective example, you can tell that patients with severe asthma with this red stain of muscles have a lot more airway smooth muscles. And when they looked at the quantitative analysis, you can see that patients with severe asthma have a lot greater airway smooth muscle area than mild to moderate or intermittent asthma, and certainly greater than COPD and healthy controls. So these patients have a lot more muscle mass, and therefore they tend to have greater constriction for a given stimulus. One of the studies that looked at this, the structural cells or the mesenchymal cells, evaluated what happened to the cells after the allergen challenge. This is quite interesting because they gave this patient with allergic asthma inhaled allergen. And then they went back and they did biopsies and looked at the eosinophil in their airway, which they were increased. But very interestingly, there was a significant increase in their myofibroblasts, which these are the cells that are at the interface between fibroblasts and airway smooth muscles. So allergic inflammation also increased the number of structural cells. So we have increased matrix protein, as well as the cells that can contribute to airway narrowing in response to allergic eosinophilic inflammation. So what to do about that feature, that structural change? One of the treatments that developed to try to address airway smooth muscle is called bronchial thermoplasty, which is basically a therapeutic bronchoscopy where the bronchoscope is introduced to the airway. A basket is deployed, and this basket is heated, and the heat is presumed to coagulate the airway smooth muscle and basically prevent them from their ability to contract. And you need to treat all the airways to basically to be effective. Therefore, it takes 2 to 3 bronchoscopies to get to all the branches of the airway and treat them effectively. And while not free from controversy, there are enough studies now to show that if you treat patients with bronchial thermoplasty, they actually have improved quality of life and reduced exacerbations. So this is one of the pivotal trials, and looking at the AQLQ, which is Asthma Quality of Life Questionnaire. And for this questionnaire, an important improvement is 0.5. And what we're showing here is the improvement after therapy. And this is a very unique study because this is an intervention that included an active heat and a sham treatment where the patient had bronchoscopy with everything and all the bells and whistles without the active heat. So this was a sham-controlled surgical intervention, which is quite unusual. Nonetheless, here's what you can see is this is the improvement from baseline. Sham bronchoscopy led to 1.1 unit improvement in asthma quality of life questionnaire. I already mentioned to you that as a meaningful improvement is 0.5. So sham bronchoscopy is quite good at improving these patients' quality of life, and but not quite as good as the real treatment improved them by about 1.3, and there was a difference with 0.2 between the two, and this led to approval of the procedure, and it is available through our interventional bronchoscopy interventional pulmonary team and the advanced asthma clinic. So moving from structural changes in the airway smooth muscle and the fibroblast to something that really has received very limited attention, which is mucus. The number of treatments we have now to address mucus is totally 0, and it is really quite an important feature of asthma, as you well know if you talk to any of these patients. Here's a picture of a patient with goblet cells, hyperplasia. Again, this is just to illustrate that it can be seen in patients with mild asthma, although more severe asthma probably have more of it. This is an autopsy from a patient who died from asthma, and you can see that all these blue cells, these are mucus gland and goblet cells are secreting a lot of mucus. And the mucus also not just in the quantity, but there are probably some changes in the rheology that make it more thick. And therefore, these patients end up with bronchial cast sometimes that really plug the airway. Needless to say, inhalers don't work if you have that kind of a mechanical obstruction. This is what you see in some patients who die from severe asthma, where the airways is totally occluded. And again, very, very few things work in these patients among the drugs that we have available. So, as some of you know, we are part of the NIH-funded severe asthma research program. We've been part of that for 3 funding cycles, totaling 17 years, and we just got renewal for another 5 years. So these are studies that have been ongoing here for quite a while. And one of the studies that was done recently tried to address the issue of mucus in the airway and how that might relate to disease severity, and just try to get an inkling of what might be causing the greater production and the changes in the rheology of mucus in patients with asthma. The study was led by our collaborator from UCSF, Eleanor Duncan and John Fahey. And also important to note is that this study did not use biopsies or direct invasive measurement. It used high quality CT scans that were evaluated by 5 expert radiologists. A couple of them are our colleagues here in Madison. Mark Schiebler was the senior radiologist looking at these and trying to get a quantitative assessment of how much mucus plugging there is. So they would go to each segment and give it a score, whether it is plugged or not, and then divided these groups into 0 plugs, low, which is less than 4, or high, that means more than 4 segments that have mucus plugging. And then they compared the clinical features of patients with severe asthma to their mucus plugging scores. And lo and behold, those with high mucus scores, shown here in orange, have significantly lower FEV1, and in other things that I'm not showing in the slide, they have more risk of exacerbations as well. So it does seem that we can actually quantify this, the mucus, and it does have a direct clinical implication in severe asthma. So, what might be causing this? One of the things that was kind of very intriguing was that there was a correlation between the percent of sputum eosinophils and the mucus score. So you start thinking that the eosinophils might be actually contributing to at least the plugging of the airway. The production might be under different things such as IL-13, IL-9, but the quality might be changing because of the eosinophil. And one of the hypotheses that they're proposing is that the eosinophil peroxide, which is a granular protein released by the eosinophil, might be affecting the cross linking of the mucin in the airway. So because of that, the mucus changed from thin and easily excreted to thick, sticky mucus that cause plugging. And thick, sticky mucus is a source of problems and difficulty for patients, and currently we don't have treatment option for those patients. So when they get plugged up, there is really not the ultimate outcome in some of these people is having these bronchial cast that they expectorate either as small segment or sometimes as a cast of a bronchial tree like I showed you earlier. So now there are actually a renewed effort to try to understand that mechanism and to see, is there a way to intervene? If we cannot reduce the production, can we do something to improve the quality of the mucus and make it easier for the patient to excrete their secretions and get relief? So now I'm going to actually summarize the airway remodeling part. And what I've showed you is that airway remodeling includes various features, including airway smooth muscle mass increase, subepithelial fibrosis, and mucus gland, as well as goblet cell hyperplasia. We talked about targeting airway smooth muscle with bronchial thermoplasty, which has been shown to improve asthma quality of life and reduce exacerbations. I totally understand if somebody kind of was saying, well, but look, there was a good improvement with placebo, and that is really, again, an area of controversy that continues in this field. Mucus plugging is really appears to be a very important feature in patients with more severe asthma. We know that from the clinic, when you ask patients about what troubles them the most, often that inability to cough, inability to get relief from their bronchodilator inhaler is a big problem for them. And at this time, unfortunately, we don't have any treatment that are directly effective. There have been multiple things that have been tried, including therapeutic bronchoscopy, where you go into the airways and wash the mucus plug and try to get relief. And in theory, that might help. You could think of it if somebody's in the ICU and intubated and their airway is blocked, that might be really a way situation where you can help. But it does not seem to be a good practical option for ambulatory patient because probably there is more where that came from. So even if you relieve that acute plugging for that one time, there'll be more production, and whatever caused them to be thick and sticky probably will continue and will cause them to be thick and sticky again, and they will have problems. Therefore, there are actually now studies that are funded by the NIH to examine various therapeutic approaches, specifically targeting the mucus and its quality in patients with asthma. So stay tuned. I'm going to move in the last part of my talk to systemic implication and connection of asthma. This is a new area for our group, and we are very excited about the expansion and the new collaboration that we are forging. One of the earlier studies was done by our very own Dr. Matt Tattersall in cardiology, in working with Jim Stein. And he asked the question is, does asthma increase the severity, increase the risk of cardiovascular event? And is that related to the severity of the disease? i.e., the more severe the asthma you have, the more risk of cardiovascular event you have. And what he did is he took a large epidemiological studies funded by the NIH that has nearly 7,000 patients and took them from baseline and evaluated them over many years to find out who gets cardiovascular event and what are the correlate a clinical feature of those patients who get the cardiovascular event versus those who don't. And this is a very unique study that is ethnically diverse, large, and like many other epidemiological studies, particularly in cardiology, they have a ton of rich data to be explored. And what Matt did is he looked at patients with intermittent versus persistent asthma. And he defined persistent asthma as any patient who's taken controller therapy, ICS, inhaled corticosteroid, or long-acting beta agonist. And the patient with intermittent asthma, those who are not taking them, they just simply take an albuterol. And he wanted to find out, is there a difference between those two groups in the risk of cardiovascular event? And are they different from healthy controls? And here's what he found. This is a Kaplan-Meier over 12 years. And the dark one is the patient who are asthmatics who are taking controller therapy, and much fewer proportion of them were free of cardiovascular event after a decade of observation. And he did modeling and adjustment and statistical consideration, and what he concluded is that patients with persistent asthma have 1.59, 60% increase in risk of cardiovascular event compared to healthy people. Now, intermittent asthma was not as bad, it was barely increased. So it was related to the disease severity. So think about it. Asthma, when persistent and more severe, is leading to cardiovascular event. And we know that cardiovascular event, asthma doesn't kill a lot of people, it kills few, but cardiovascular events are a major source of morbidity and mortality. Therefore, it becomes much more important to understand why is that connection, and can we do anything to prevent that crosstalk between the airways and the heart. He then went on to look at earlier stages of asthma, taking advantage of the childhood origin of asthma study, the COAST, which is led by Drs. Jim Gurn and Rob Lemansky, and more recently, Dr. Dan Jackson. And this study evaluated the association between asthma and atopic disease on one side and antecedent of cardiovascular event by looking at ultrasound of the carotid bodies. They have 89 participants from COAST, and the study basically just evaluating that birth cohort, and now they're almost 20 years old, and they're finding out who get atopy, who get asthma. And to enrich that sample, they took patients who are at risk. They have parents with allergies, both parents with allergies and asthma, so to make sure that there's enough event in that group. And Matt took advantage of that cohort to look as, do we have any early telltale sign of cardiovascular event in younger age in relationship to asthma? So here's what he found. Whether it is asthma with atopy asthma without atopy, asthma and atopy, all of them were associated with increased carotid bulb thickness, which is a risk factor or indicator of future cardiovascular event. The greatest risk was in those who have atopy as well as asthma. So this is a very, these again, keep in mind, these patients, these volunteers, they're not even patients who are taking medication. These are really young people in their late teens, and even at that age, with a very mild disease, with a very sensitive technique, admittedly, Matt could actually find thickening of the walls of the carotid with risk for future events, cardiovascular events. So we moved up from the carotid here to the head and looking at the relationship to the brain. The connection between brain and asthma has been an area of interest for the group, mainly Dr. Bussey and Dr. Davidson and Dr. Rosenkrantz in psychiatry for quite a while. But it has taken on greater interest with more epidemiological evidence of connection between asthma and brain dysfunction. And the question we're asking now, does inflammation in the lungs, when uncontrolled and untreated, does that cause neurodegeneration? Does that cause damage to the brain, either directly by causing glial inflammation or indirectly by causing vascular damage, like I just showed you in the study by Matt Tattersall? So this started a number of years ago when they did functional MRI and evaluated activity in the brain in areas that had to do with emotion and sensitivity, et cetera, and what happened in these areas when somebody is getting inhaled allergen challenge. So we're looking at functional MRI of patients with asthma when they inhale allergen. And what they found is that there is activation in these same areas in relationship to having eosinophils in the sputum and dropping the lung function during the late phase, which I told you has to do with recruitment of eosinophil to the airway. So even back then, from almost 15 years ago now, the studies have linked activation in the brain MRI, functional brain MRI, with feature of asthma, including physiology, late phase response, as well as eosinophilic inflammation. So more recently, we looked at patients who have asthma, as well as age-matched control that are being studied in the Center for Healthy Mind with Dr. Davidson and Rosenkrantz. And what they wanted to look at is the integrity of the brain by functional MRI. And there are a number of very sophisticated techniques that they have used to try to get to the question is the brain suffering any negative impact from the presence of asthma, its severity, or lifelong burden of asthma? So here's one kind of example of looking at how different is the brain in asthmatics versus normal. And the ruler here is by the color where the more red is more different. And this is basically an indication of the damage to or neurodegeneration. And what you find out is that patients with asthma have greater indicators of neurodegeneration than normals. So that's kind of a concerning, is we have a disease that we think it's a lung disease, but now it's having a clear systemic implications. Not only that, but patients with more severe disease for longer, and that's kind of was translated to a lifetime burden, so the severity multiplied by the duration. When you do cognitive functional testing, the longer and the worse the disease, the worse cognition. So now we're having a disease from the lungs that is affecting the brain and causing worse cognition, which is one of the features of dementia. We have also evidenced that the blood eosinophils, one of the feature of allergic inflammation, the greater the blood eosinophils, the more age discrepancy in the brain. You can actually assess a brain age by looking at the MRI. And if your brain MRI age is greater than your age, that means you're losing. And that's what's showing here, is that those patients, their brain is aging faster the more eosinophils they have in their blood. So somehow, greater eosinophilic inflammation is damaging the brain and causing accelerated aging of the brain, which is one of the features of cognitive dysfunction and dementia. The same was true if you add another feature of allergic inflammation, which is exhaled nitric oxide, and translate basically the sputum, the eosinophils as well as the exhaled nitric oxide into a score. The greater that score, the greater discrepancy or aging, accelerated aging of the brain. Very, very important, and certainly very concerning, because we are not certain at this time, we're not sure whether our treatment that targeting symptom relief of patients with asthma is adequate to prevent this damage to the brain. What if our therapeutics are only good enough to prevent the symptoms, but are not doing anything about the inflammation that is influencing not only the lungs, but also the future health of the brain? So let me summarize this part. What I've showed you, I hope, is that patients with persistent asthma have 60% increase in the frequency of cardiovascular event, the studies by Matt and Jim Stein. Even in children with asthma, they have greater carotid artery wall thickness, which is an antecedent to cardiovascular disease. Asthma, it appears at this time from preliminary studies that it is associated with neurodegeneration of the white matter and accelerated brain aging, with implication for earlier dementia. And these markers of neurodegeneration were greater in patients who have more severe asthma and more lifelong burden of asthma, as well as those with type 2 inflammatory indicators such as eosinophil and exhaled nitric oxide. So we have an epidemiological association, and we have the very early signs or indicator of a possible pathogenic correlation between allergic eosinophilic inflammation and damage to the brain, with important dysfunction down the line. The Department of Medicine is quite insightful when they recently awarded a multidisciplinary science pilot study funding to a research team led by Drs. William Bussey, Barb Bendlin, Melissa Rosenkrantz, and co-investigator from the Allergy, Pulmonary, Geriatrics, and Psychiatry Department. And these studies are based on the findings that I shared with you, will examine the relationship between persistent airway inflammation and asthma and the risk of neurodegeneration, including Alzheimer's disease. And these studies will look both at the direct impact with the eosinophilic inflammation, as well as the indirect impact through vascular abnormalities. So, in conclusion, I hope I showed you that eosinophils play a very important role in asthma pathophysiology, and that targeting eosinophils with anti-IL-5 reduce exacerbations, but only by 50%. So there's something else going on here, and why it doesn't work in everybody? Perhaps because the eosinophil, when they get to the airway, they lost IL-5 receptors, so they don't really care how much anti-IL-5 you give them. Or perhaps now another cytokine took over, such as IL-3, and IL-3 is elevated in the airways, and the receptor is augmented, so maybe that's what's happening. Or maybe the airways have progenitor cells that are under the influence of allergen are becoming eosinophils. We don't know which one for sure, but we are actually actively investigating that. I showed you that bronchial thermoplasty targets the increased airway smooth muscle, which is an important feature of severe asthma, and it does seem to improve, at least to some degree, the quality of life of these patients. Mucus plugging is probably a very, very important feature in patients with asthma, particularly severe disease. And it has received very limited attention until now. But we're starting to do more studies on that using very accurate CT scanning and trying to understand the possible contribution of eosinophil to the quality of mucus, not just the quantity, by making it thicker and stickier and more difficult to excrete. And I hope I showed you at least some early exciting features that persistent asthma may lead to increased frequency of cardiovascular events, neurodegeneration, and accelerated brain aging. These systemic complications are potentially related to the disease severity, life-term burden, or persistent eosinophilic inflammation. I hope that one of us in that research team will come back to you in a few years and give you some more definitive, exciting data about the systemic implication of asthma, particularly eosinophilic disease. I want to thank all of you for coming here. I want to thank my collaborators on this effort, Stefan Hinault, Becky Kelly, Lauren Denlinger, Dean Mosier, Jim Walter, and Samir Mather are my partners in research for the program project grant. And we've been working together for nearly 2 decades on these studies, some of us for longer than 2 decades. Research on the brain connection was done by Dr. Bussey, Melissa Rosenkranz, and Richie Davidson. And the research on the cardiovascular connection has been done by Matt Tattersall and Jim Stein, and we are aided by a very capable research manager, Tina Pallas. Thank you all very much for coming. Happy to take questions.
Questions?
Bennett.
Nizar, thanks for sharing just what is a remarkable career of investigation into the questions of this common illness. So are we at a point yet where we know which phenotypes might progress to more smooth muscle aggregation submucosally, and do anti-inflammatories work to prevent that from occurring? Can we prevent the matrix change? Can we prevent the smooth muscle accumulation with the agents that we currently have if we catch it early enough?
Thank you. So Dr. Vogelman's question is, do we have ability to prevent the remodeling event from happening if we treat early on with anti-inflammatory medications? And the answer is, this is a $1 million or $10 million or $60 million question. Pharmaceutical companies are hoping that actually this would be the case. But as you well know, a lot of these clinical trials are done mainly to get FDA approval, and all you need is 26 to 52 weeks and showing an improvement over placebo, and you get that drug approved. It's hoped now that over the last 5 years, we've had 4 different monoclonal antibodies that are added to the market to treat patients with eosinophilic and allergic asthma. So it is really hoped that in the near future, in the next 3 to 5 years, there will be studies addressing exactly that question. And the hope is that if you prevent the eosinophil from coming and being active for long enough time, could you reverse some of these changes? And at this time, we don't really have a clear-cut evidence, but it's hoped that it will happen.
So neutrophils form extracellular traps, which is release of DNA in a form of programmed cell death, and it's associated with sepsis and thrombosis. Is there a parallel process to eosinophils, and would that be contributing to this mucin, not just the mucin formation, but the mucin cast? Has there been any analysis of what's in the mucin cast?
So the question is, is there a parallel event with eosinophil to what we know happened in neutrophils, which is the release of DNA, a process called mitosis? And the answer to that is yes, there is something similar in eosinophils. The answer to your second part is that release of DNA outside the eosinophil related to the mucus quality or rheology, and I don't think we know the answer to that part. It does make sense because we know that in other conditions where there's a lot of DNA in the airways, there's thick mucus such as in cystic fibrosis, but I have not seen anything that connecting this directly to the eosinophil quality, to the mucus quality. Yes?
Is there any histopathologic evidence that the eosinophil has a role in either atherosclerosis or neurodegeneration?
So the things come, what we really do know is that eosinophil contribute to myocardial like fibrosis. If you have a patient with hypereosinophilic syndrome, they get a lot of myocardial fibrosis. We also know that there is a love affair between the eosinophils and the nerve because a lot of the time they're close to each other. Whether we actually we have any direct evidence that the eosinophil itself is going to the brain and infiltrating the brain tissue, I have not seen anything to that effect. But they don't need to travel there. Their product could cause all the damage as well. So this might not be a very easy question because their absence from the scene of the crime, it doesn't mean that they're innocent. Steve.
So Nizar, wonderful story. I'm wondering, to what extent is aging, which itself in some people's perception an inflammatory process, to what extent is aging a factor with some of these response curves that you were talking about with respect to some of the Bronchial studies?
So the question is, the aging is an inflammatory process by itself. How much of that is the contributing factor? And the answer is absolutely, you're correct. We actually have some of the experts here. Dr. Keith Meyer did some of those studies on aging and enhanced inflammation. Dr. Samir Madha did some of those studies as well. And so that is actually, for sure, is a contributing factor. But a lot of the studies where they're looking at the brain aging and the studies with the cardiovascular adjusted for aging as well. So I do think it is probably contributing part of it. But even if you take it out, there is still an independent contribution from this inflammatory event. Molly?
That was great. Great way to start the year with a great background.
Thank you.
So it strikes me that there are a lot of environmentally induced causes of essentially asthma, right? With all the fires in California, the fires in Australia, India, you know. So do people who have this sort of environmentally induced asthma, do their brain changes and other things change when they move away from these areas?
So the question that Dr. Carnes asked is, with all of the changes in the environment and the fires, there's more asthma, and if you move from that area where there's more of these stimuli, does your brain function improve? And I don't know of any studies looking at that particularly, but we do know that if you move out of the area where there's a lot of allergic stimulation, you actually get better. They've done those studies when they take young kids, teenagers, and they move them to the mountains in the Alps where there's there's hardly any allergen there, and their asthma actually does get better. So if you remove the stimuli, your asthma get better. Does that lead to improvement in the brain? Oh, we really are probably a decade away from finding anywhere close to an answer to that. Dr. Jamali.
Dr. Jarjour, wonderful presentation.
Thank you, sir.
You presented some data on cytokines IL-5 and 3, and you also showed that about 50% of symptoms get better.
Yeah.
But what do we know about eosinophil-independent mechanisms and other cytokines? There are probably 20 or 30 cytokines generated by eosinophils. How do you pick specifically IL-5, IL-3, and what are your thoughts?
Very, very good question. So Dr. Jamali asked, well, you presented some stuff about IL-5. How about the other cytokines? What do we know about the other cytokines? And the answer is twofold. One is experimentally, this seemed to be the kind of the more consistent cytokine that goes up when the eosinophils are present. But also practically, they've tried the other anti-IL cytokines. They've tried anti-IL-17 and anti-IL-13, and at the bedside, they didn't seem to work as well as anti-IL-5. Also, a very important lesson here for many of us who are involved in clinical trials. When they did anti-IL-5 treatments initially, this was about almost 20 years ago, the companies were interested in trying it in everybody with asthma. So they gave it to these patients, and lo and behold, it did not work. So they put it on the shelf, and they ignored it until one of the investigators really wanted to try it again and convinced the company to actually fund a study that they did. And their idea was, well, you were giving anti-IL-5 to all comers. But what we know is that it's only worked for the eosinophils. So if you didn't have eosinophils, how in the world do you expect it to work? And therefore, the subsequent studies were done only in patients who have eosinophils. And if you have that selection, patients with eosinophils, and you treat them with anti-IL-5, it does work. So now you might ask me the natural question is, did they do the same thing for anti-TSLP or anti-IL-17? And the answer is probably not quite, because they tried that with anti-IL-13, where they did one of the downstream effect product, which is periostin, and look at level of periostin in these patients because it's a downstream from IL-13, and treating patients with anti-IL-13 who have that event. One study was positive and very encouraging, and the other one was not. And as you know, clinical trials are not always showing what you like them to show. So, Dr. Mackey.
What has perpetuated asthma in the population? Why isn't it washed out? Is it because these patients have a greater host defense against parasitic infection. Is that what's perpetuated asthma in the population? Because if there's a biologic advantage somehow to be able to mobilize a lot of eosinophils in the lung, and if that's indeed the case, is there asthma in Eskimos who have far less exposure to helminths?
So Dr. Mackey's question is that, do we have regional variation in asthma prevalence that might be related to exposures to infectious agent? And the answer is absolutely yes. So what we do know is that people who live in industrialized areas, such as the United States and Europe or New Zealand, have a much greater prevalence of asthma than people who live in places such as sub-Saharan Africa. So it does seem that potentially the infections, such as even measles and viral infection, et cetera, which may be shifting the response to a type 2 as opposed to a type 1 anti-inflammatory response, are protective against asthma development compared to an allergic response, which is more eosinophilic and more asthma prone. So that's absolutely correct. Yes, Keith.
To Dennis's question about parasitic infection, but what do we know about the lung microbiome or the gut microbiome and kind of controlling what's going on here? Is anybody really looking into that? That may have quite an influence.
Yeah, so that's a very important question that Dr. Meyer is asking about. How about the microbiome? And the answer is absolutely yes. This has been an area of investigation for our severe asthma research program, where we have shown by looking with bronchoscopy as well as by looking at other means that there are clear-cut differences in the composition of the microbiome in patients with asthma, particularly those who are on controlled therapy with inhaled corticosteroid. We have taken that observation into the next study, which is our PRECISE, which is our treatment continuation of severe asthma, and we are giving people bacterial product called bronchovaxum to see whether changing the microbiome help improve asthma control and patient well-being there. So yeah.
One more, please.
One question.
Dr. Liu?
We monitor function, the pulmonary function with PFTs and whatnot. But what you're pointing out is that the big cause is the inflammation. So why not use FDG PET and get spatial temporal change? Is that used? Is that clinical? Is that a research tool?
So Dr. Liu is asking, how about using PET scan to evaluate inflammation in the lungs, since it seems to be very important. So we have used it as a research tool in one of our studies, and it does light up when you have an acute exacerbation, particularly with virus infection. So we actually have done those for research studies. Obviously, using it clinically for evaluating a disease that go up and down and patient actually at risk for at least one exacerbation per year is quite expensive and might not be as practical. There are other ways of evaluating inflammation. So one of them is looking at exhaled nitric oxide, and that could be one tool to tell you if somebody is actually having eosinophilic inflammation. Another tool is looking at sputum, induced sputum, and measuring the number of eosinophils in the sputum and treating patients if they have high eosinophils with more inhaled corticosteroid to suppress that down. The problem with sputum eosinophils is not easily done technically. Therefore, at this time, we and others are trying to find out whether we can actually predictably and reliably measure eosinophil products, such as the ECP or EPO, in the sputum by like a dipstick, if you would, so that it becomes much more reliable and easily applicable at the point of care. So, right on.
Thank you all for coming to Medical Grand Rounds. Thank you.
Thank you very much.